Welcome to today's live stream. And what I want to do today is to study. So I need you to study with me. I'm studying renals. Yeah, so feel free to ask me any question. I'll be super excited to answer. Don't forget to like and subscribe to the channel, guys. Okay, I'm done with this. Let's do some questions. Liddle syndrome is metabolic alkalosis. Person should have hypertension though. If you have Liddle syndrome, you should have hypertension. It works like triazide diuretic, I think. Yeah, you should have hypertension. Ooh, good. We got that one right. Which of the following is secreted in the collecting duct? Goes out. Sodium is reabsorbed. Secreted should be calcium. Yeah, should be this one. Yep, that's one right. Good. Making progress. Number collecting duct is here, number 8. In the collecting duct, ADH increases the reabsorption of water, I think. Yeah. Let's see. Got it right. Which of the following is true of aldosterone in the collecting duct? Decreases aldosterone works binds to V2, yeah, receptor, and then no, that's ADH. Aldosterone would react with reabsorb sodium, okay, and it too would follow. So it would also simulate, and no, it doesn't inhibit. So this is wrong. It simulates the pump. It increased the secretion of potassium. I think that's the correct one. Increased secretion of potassium. So I need to lock that in. So aldosterone reabsorbs H2O, so water will follow. So when you reabsorbs H2O and water follows, thank you for joining me today. I'm just studying. So when you I'm studying for renal exam. I'm a medical student, first year. So and I'm a mom of 3. So this is like me having a redo in life. So I'm happy to have you join me on this channel. Yeah, thank you for the likes, the subscription. If you're interested in seeing me through this journey of becoming a medical doctor, then please subscribe to the channel. I have an exam in about 5 days. So this is me trying to study and come in life. Yeah, so learning about the renal system. That's the kidneys, the nephrons, the bladder, ureter, and all that. Yeah, so we can learn together. By the way, my name is Kemi, and yeah, nice to meet you all. So I'm just looking at aldosterone. So there's something that we call the connecting duct. It has 2 hormones that works in it. Hi, how are you? I'm good. Hi, Strawberry. Thank you for joining me today. So it has 2 hormones, ADH and aldosterone. ADH helps with reabsorption of water. So anywhere water goes, sodium goes with it. So when it reabsorbs water, that means it also reabsorbs sodium, right? But aldosterone works in the way that, so that's what aldosterone do, right? And it stimulates the ENaC, That's the epithelial sodium channel, and it also helps in sodium potassium pump in stimulating those two. So it stimulates NAC and sodium potassium pump, and now it will secrete out potassium. Push it up. Thank you. Keeping it up. So yeah, so that's the fifth question, and I got that right. Happy. Which cells in the collecting duct reabsorbs bicarb? That's HCO3. Reabsorbs. So I have a cheat code. I used to learn it. We have alpha and beta, and then alpha works on acid, secretes acid, and reabsorbs bicarb. So that will be the alpha intercalated cell. Let's see if I'm right. Yeah, I got it. I got it. I strawberry. I'm just reading. I'm just studying for an exam, and I'm doing it live. I'm gonna be here for like 5 hours. Like this girl, we need to pass this exam once, and I'll keep you updated though. The examination is next week Wednesday for my finals on renal, and up until now I've been doing okay, getting 70s. I want to see if I could push myself to getting an 80 in my exam. So let's see how that goes. Which lab finding are you most likely to find in a patient with syndrome of apparent mineral curtailed excess? That will be same. That's the name of the disease. It's a syndrome that is autosomal recessive. So when it's autosomal recessive, it means that both genes are mutated, and then you can always pass it to the next generation, okay? But it's mutated. It's not, you have the gene, but it's not active in you. Then you can pass it to the next generation. Hopefully it's not going to be active in them. What's my favorite subject? Good question. I think my favorite is microbiology because of the lecturer we have. It just, the way it teaches you before you leave his class, you already know like 60% because it teaches with active recall, keeps repeating the same thing, going back, making you tell him the answers. But however, microbiology is not high yield in exams. Oh, I need to know my pathology. Pathology is really, really high yield. Same with physiology. So, and I'm not so good in those, which is why I'm reading. Back to the question. This person will actually have metabolic alkalosis, is autosomal recessive, and it will decrease aldosterone. So I think this should be the answer. Perfect. Got it. We got it. Let me read the notes to make sure I have it down. Syndrome of apparent microcurtailed excess is autosomal recessive loss of function, mutation resulting in deficiency of 11 beta HSD, convert cortisol to inactive. Oh, I didn't put that down. I need to put it down. Convert cortisol to inactive. Hi everyone, thank you for joining me today. My name is Kemi and I'm just studying. Wow, so good. Thank you. Thank you so much. To inactive cortisone. Okay. So that means it reduces aldosterone, increases cortisol. Okay. Makes sense. So out of 7, we got all 7, which is good. Happy and excited about that. Now I'll move to the board exams. These ones are really, really tough and difficult.
Go ahead and pause the video, review this question, select your option choice, and then we'll go through all these answers shortly.
So let me pause it, look at it, and then see if I'm gonna get the question. It says here that a 16-year-old girl is brought to the clinic by her mother because of progressive fatigue and lightheadedness over the last several weeks. The mother states that her daughter has recently withdrawn from social activities and has become increasingly preoccupied with. The patient denies engaging in self-induced vomiting or using laxative. Vital signs shows a blood pressure 90/60. I think that's okay. A pulse of 110. The patient has a BMI of 17. That's okay too. Physical examination reveals dry mucous membrane and decreased skin turgor. ECG shows flattened T waves, presence of U waves. Result of laboratory shows the rest. Okay, let's see how that would go. So So the mechanism of action responsible for the patient's condition, I want to believe might be aldosterone receptor antagonist. Let's see if that is correct. Got a message now. Let me see. Okay, not important. Hi everyone, thank you for joining me. Just a medical student studying for a renal exam. My name is Kemi, and if you're new to the channel, thank you, and kindly subscribe to walk with me on this journey, and let's see how it goes. So I'm trying to solve a question here. I'm guessing it's A. Let's see how true that is. Fingers crossed.
All right, so the correct answer for this question is option E, which is the sodium potassium 2-chloride symporter inhibitor. Let's walk through this question 7, think about how we can derive this based on the information that we learned in the nephrology chapter. So first, let's talk about some of the things the question gives us. First, they give us a general presentation of the patient. So 16-year-old girl is brought to the clinic by her mother because of progressive fatigue and lightheadedness. So right there in the beginning of the sentence, we're getting the rationale for this patient coming into the clinic. What were those primary symptoms? And we'll start to kind of build a differential in our head for what kind of things could potentially lead to these symptoms. Or in this case, what kind of mechanism are we looking for that could lead to these findings? The mother states that her daughter has recently withdrawn from social activities and become increasingly preoccupied with her weight. The patient denies engaging in self-induced vomiting or using laxatives. This can be helpful for us, right? They're giving us a clinical clue about something we might be thinking about. Is the patient using these things? Is that why they're hypotensive, the fixation on the weight? Well, let's read to learn more. We see the vital signs show a blood pressure of 90/60 millimeters of mercury. And to me, this is a pretty significant finding because this is pretty low. If we just take a baseline of 120/80 being normal, 90/60 is definitely on the lower end. So it's kind of catching my attention as I read this question stem. Like, this might be an important clue as to the patient's presentation. Let's learn more. We also have a pulse of 110. Again, this is a helpful reactionary step that the body takes so that you get tachycardic to help compensate for the low blood pressure. We also find the patient has a BMI of 17. Now we move on to the physical exam and we see some more notable findings such as dry mucous membranes, decreased skin turgor, and the ECG with flattened T waves in the presence of U waves. So now this is something that we need to be familiar with. When ECGs present with flattened T waves in the presence of U waves, what condition is that typically associated with? That's right. Typically, we think about this being associated with hypokalemia. And the flip side of that is what's associated with hyperkalemia. That would be the peaked T waves that they would show you on ECG. Now we're going to draw our attention down to the labs. And anytime I'm going through labs, I always kind of break things into two simplified categories. Is it normal or approximately normal, or is it grossly abnormal? That's going to catch my attention. So roughly the sodium of 134, we typically say a sodium is going to be about 135 to 145. So this is a little bit low, but it's not really grabbing my attention. But what is going to grab my attention is the potassium of 2.9. This is very low, and it's actually helpful to make this connection because we have a confirmatory ECG that also shows us signs of hypokalemia. So we're starting to build this presentation and feel more confident that whatever's going on, whatever mechanism is involved, it's probably dealing with potassium in some way, shape, or form, because we now have multiple clues that this patient is clearly hypokalemic. As we move further through the labs, we also see the patient is hypochloremic. So this is on the lower end for normal chloride as well. Now, further making our way down the labs, we see a bicarb that's a little bit elevated, a urea nitrogen and creatinine that are also a little bit elevated. Together, these kind of paint a picture of hypovolemia or low volume states, right? If a creatinine typically is around 1.0 as just a general rule of thumb, 1.5 indicates that maybe there's more of it being built up and not enough of it's being filtered, which can be a sign of damage to the kidneys. The other things that really catch my attention here is that the magnesium is on the low side and the calcium is on the low side. Those are the labs that really stand out to me. They're all a little bit outside of the normal range, but I definitely try and prioritize which ones really stick out. That low magnesium, that low potassium really catch my attention, and I just kind of made a general note as I'm going through this. Well, most of the labs are outside of a typical range, so something's going on, some metabolic derangement is going on, and I need to figure out which mechanism is most likely involved for this patient's presentation. So to get this question right, we need to be familiar with the key nephron transporters that are talked about in this chapter. And so just a brief review, kind of, if we think about our nephron, right, we have the Bowman's capsule, the glomerulus, right?
Chloride.
The afferent arterioles coming in, the efferent arterioles leaving, then they get filtered into the PCT, or the proximal convoluted tubule, goes through the thin descending limb and the thick ascending limb of the loop of Henle. Then they go into the DCT, or distal convoluted tubule, finally into the collecting duct, where it will then further on go into other processes that we'll learn more about as we build on nephrology knowledge. But the key here is to know the transporters that are needed to answer the question, which of the following best describes the mechanism of action responsible for this patient's condition?
That would
we're given
mean
several different answer choices. We said the answer is E. Why is the answer choice E? So let's start by going through the answer choices and determine why each of the incorrects are incorrect, and thus why the correct answer would be the best option choice in this instance. So first, the aldosterone receptor antagonist is not the best answer here. And why is that? Well, first of all, think about the action site, which is primarily in the collecting duct, where you have a receptor that aldosterone will go and bind to. Well, something that's an antagonist is going to basically block that from occurring, right? So some examples include things like spironolactone, eplerenone. And so if an antagonist binds, we're going to basically knock out this channel. So it's going to do the opposite of what aldosterone will do. We know that the activation of aldosterone is primarily involved in the pathway of the RAS system, which is the renin angiotensin aldosterone system. And what's one of the primary goals of the RAS system? It's to increase the absorption of sodium. It's typically something that is done in low volemic states or low solute, such as sodium chloride states, to bring back more sodium, because if you bring back more sodium, we know from the principle of osmosis that water follows solute. So if we have a bunch of solute on one side and less solute on the other side, where's the water going to flow? It's going to go this direction. So now this alone can make sense, but what are some other things that happen when you activate this system, which is that you get increased secretion of potassium and hydrogen protons. So again, we have to think a little bit backwards in our head. If activating the RAS system brings back sodium and secretes more potassium and hydrogen protons, what is an antagonist going to do? Which is what option A says. It says it's an antagonist. It's going to do the opposite. So something that antagonizes aldosterone in the RAS system is going to lead to low sodium, which could be reasonable based on our patient's lab. It's mildly low, but it's going to lead to less secretion of potassium, and thus we'd have higher potassium and higher hydrogen protons, and that is inconsistent with what this patient has. They have a low potassium, they have hypokalemia, and thus A is not the best answer choice. Well, what about option B, a carbonic anhydrase inhibitor? Why is that not the best answer choice? What acts in the PCT to actually block bicarbonate reformation and thus reabsorption? So more of it leaves the body, and you actually get a low amount of bicarb. But here in this patient, we're on the higher side, and additionally, this mechanism would not explain all of these different things that are going on, right? There's a lot of lab abnormalities here. We need something that explains more than just one piece or two pieces, and thus this would not be the best answer. Now, why wouldn't an osmotic diuretic be the best answer? Well, that's because these primarily are going to affect the balance between water and sodium. And that's to say, an osmotic diuretic can actually
intravenous,
the process of osmosis that we talked about over here.
Diarrhea.
It basically adds more substance. So if you add more substance, you pull more water.
Useful
that can cause diuresis or loss of those fluids, which can certainly affect overall water balance and even sodium, But again, it does not account for all of the findings that are discussed in this question. We need something that has multiple effects on potassium, magnesium, calcium, and this alone would not sufficiently answer the question. So what about option B, the sodium chloride?
I'm trying to do active recall. Let me see if I'm right about mannitol. Yeah, so it's a osmotic diuretic, that's mannitol, and what it does is to draw water. Okay, so it will act on the PCT and the loop of Henle. Okay, it's used for edema, like cerebral. It draws water. So if you have swelling, cerebral edema, we need to use that osmotic diuretic like mannitol to draw water away from the brain, or for congestive glaucoma. And the side effect is that it could lead to pulmonary edema or heart failure when there's too much water. Okay, sounds good.
Symporter inhibitor. Why is this not the best option choice? This might be actually tempting because maybe it explains the changes in the sodium and the chloride for this patient. Now, typically these are going to work at the distal convoluted tubule, or DCT. And as the name suggests, these are most commonly going to affect the sodium and the chloride itself. But again, we have to be able to answer for why is magnesium and calcium affected. And so while these can characteristically decrease sodium and chloride, they actually, interestingly, act to increase calcium reabsorption, and thus this would be inconsistent with our lab. We see that we have the hypocalcemia, but we need to be able to explain that with the process that leads to hypocalcemia, whereas this process actually leads to increased calcium, because while on one side, the apical side, we have the sodium chloride channel, on the basolateral side, there's actually another channel that acts as a sodium calcium exchanger, so it actually brings more calcium in the body, would lead to hypercalcemia. So then we determine that E is the best answer here. And why is that? And so typically when we think about this NKCC channel, from the lumen, which is in here, on the basolateral surface of the cell, we are pulling back sodium, potassium, and then 2-chloride. That's where the NKCC channel gets its name from. Now imagine we inhibit this channel. What's going to happen? Well, if you go and take a medication that inhibits this channel, less of the sodium, less of the potassium, less of the chloride is going to be reabsorbed into the body. Well, where's it going to go? Now it's going to go to its next step in the DCT, and then it's going to come all the way back around in the collecting duct, and eventually it's going to get excreted in the urine. And we have to say, would this make sense? Would we see low sodium, low potassium, and low chloride if we blocked the channel that typically bring those substances back in the body? The answer would be yes. So if we block something, if we inhibit something that would typically bring back a substance, it makes sense that we'd have less of that substance in the body because it would be excreted through the urinary system. Now, the final question of this is, how do we explain this low magnesium and low calcium? Well, this is understanding a further step, which is that of paracellular reabsorption of magnesium and calcium. And so typically at baseline, this thick ascending limb of the loop of Henle is impermeable to water but actively reabsorbs electrolytes. Now we said this transporter on the luminal side of the cells, you have to imagine there's like cells in here, right? We have the luminal side, which is the lumen where everything's passing through. And then you have the basolateral side, which would be out here, where things would then get reabsorbed into the actual body itself through the vascular system. And because we are blocking this system, the sodium, potassium, chloride, there's less positive charge in the actual lumen of the cell, right? So we typically have a cell that carries a positive charge, which helps drives something called paracellular transport of other ions such as calcium and magnesium. And why is that? Because repellents, right? Like repels like, so positive charge repels a positive charge. But if you lose this positive charge, you lose the repellent, right? You're not bringing enough positive ions into the cell. You then lose the drive that's going to push other positively charged ions across. And because of this, if you're not getting paracellular reabsorption, so you're not getting the positive charge, you're not getting as much calcium and potassium that's going to go through in between the cells, where's it going to go? It's going to stay in the lumen, make its way through the DCT, collecting duct, and similarly to the sodium, potassium, and chloride, it's going to get excreted in the urine. So you can see blocking this channel has a lot of effects. So this is consistent with the type of diuretic. We'll learn more about the details of those in the pharmacology section, but you can see that blocking the NKCC channel can give us our presentation where we've lost sodium, potassium, chloride, magnesium, and calcium. And if we lose sodium, we talked about how the principle of osmosis is going to lead to less water reabsorption. That can explain the hypokalemia, some of the other skin findings, and we've connected the ECG with the hypokalemia as well. So taken together, this is going to be the best answer. This is going to explain most of our findings for this patient, and thus it is the correct answer for this question.
So help me, Lord. That's all I can say. So help me, Lord. So I'm done with that one. I'm going to go to the next one, which is the renal angiotensin aldosterone system. I hope I understand it. Lord help me.
Hey, welcome back everybody. David here again with Med School Boot Camp. So in this next chapter, we're going to talk about a very important system called the RAS system, or the renin angiotensin aldosterone system. There is a ton of unique physiology and then eventually pharmacology that plays into this system. So we're going to build a foundation of what it is, why it's important, and how it can be manipulated with pharmacologic interventions and various other ways that might ask you about it on test day. So in this chapter, we're going to do a quick overview, then we're going to talk about this molecule called angiotensin II and the specific downstream effects that it can have in the body. And finally, we're going to talk about some natriuretic peptides and key things that they want you to know in order to answer questions right on test day. And so if you all are ready, then off we go. So in this first video, we're just going to do a brief overview of this RAS system, or the renin angiotensin aldosterone system. And as you can see from our image, when we look at this, there's a lot of key moving pieces that we need to think about. And as we go through these videos, we're going to talk about all the different ways that this system can take effect, what regulates it, what can change it in an activating or inhibitory way, and we're going to gain a better understanding of why this system is important. In general, it focuses on three key things. That is fluid balance, blood pressure regulation, and electrolyte levels. And this system ensures that the body is able to maintain its iteration of homeostasis for proper functioning. So if we first just think about the regulatory mechanisms, we need to know this is hormonal regulation of blood pressure and fluid balance. This is sensitive to pressure, volume, and sodium. Sodium is an electrolyte, and it is one of the primary ones that's going to be involved in this system. There are some other smaller players, but as we dive into the physiology, you're going to see that sodium is really the main electrolyte that plays an active role in maintaining homeostasis in the body. When we think about the actual pathway of this system, it builds on a process of precursors within the body becoming an end.
So RAS, which is the full word, is renin angiotensin aldosterone system. It focuses on fluid balance and blood pressure. So it's an hormonal regulation for blood pressure as well as fluid balance. And it is sensitive to a few things. Okay, so it is sensitive to things like pressure. That makes sense. We're talking about blood pressure here. And sodium, because if you have a lot of sodium in your system, your blood pressure should spike. So sodium and volume. Okay, so that's RAS regulation, regulates fluid balance and blood pressure. It's sensitive to pressure, it's sensitive to volume, and it is sensitive to sodium. Okay, good.
And product that is activated by a very important enzyme, and that is angiotensin converting enzyme. I put a high yield by that. We're going to highlight this many times throughout the chapter, and as we start to dive into pharmacology, you're going to see this come up quite a bit as well.
Which is that angiotensin 1 is inactive and then it converts to angiotensin 2, which is the active form, and this is done by the ACE. Okay, it's done by the ACE, which I think is the angiotensin enzyme. All right, yeah, and this is high yield. So let me write that. Okay, so angiotensinogen is converted to angiotensin 1 by renin. And also angiotensin 1 is converted to angiotensin 2 by ACE. So two enzymes are working here, renin and ACE. So this is the inactive form and this is the active form. So angiotensinogen is converted to angiotensin 1 by renin. Then angiotensin 1 is converted to angiotensin 2 by ACE. Bear in mind that angiotensin 1 is the inactive form and angiotensin 2 is the active form. So what you're doing with me is studying renal system. And this is high yield. Okay, high yield. I like that in my book.
Keep that one in mind, ACE, or angiotensin converting enzyme. But how do we get to this enzyme? How do we get to this step? Well, let's walk through this process by drawing our attention to our nice image over here. So when the body senses low volume, low pressures, or abnormality in our sodium, the kidney is going to release this enzyme called renin. And what's that going to do?
I have a call, so I'm going to mute and I'll be right back, okay? Hi everyone, thank you for joining me today. I'm studying for renal exam and just going through a few slides here. If you have any question for me, please feel free to ask. I'll be super excited to answer you. And I'm on a journey to being a medical doctor, so let's study together.
Angiotensin 1 is an inactive molecule, right? It's not ready to take its effects in the body. Another step must happen, and that's what we see. This very important enzyme I highlighted, or angiotensin converting enzyme, can then take angiotensin 1, convert it to angiotensin 2, and that's the one that can actually take effects in the body. That's going to be the highlight of the upcoming video, which is angiotensin 2, which is the active form, and as we'll talk about, a whole bunch of things take effect in the body with this active metabolite. We've dedicated a whole video to breaking down these effects, but just a brief overview, some of the key things angiotensin 2 can do is that it can cause smooth muscle constriction. It can stimulate the posterior pituitary to release more ADH hormone. It can stimulate the adrenal cortex, releasing more aldosterone, and it can activate certain channels in the kidney to help bring back more sodium. The whole goal of this is that you want to increase blood pressure and total peripheral.
So I want to write down the functions of angiotensin 2. It helps with vasoconstriction of the efferent arteriole. Okay. It also helps with releasing ADH, antidiuretic hormone, which is ADH. It helps with aldosterone and helps kidney with water and sodium reabsorption. Go back.
Now these effects, but just a brief overview, some of the key things angiotensin 2 can do is that it can cause smooth muscle constriction. It can stimulate the posterior pituitary to release more ADH hormone. It can stimulate the adrenal cortex, releasing more aldosterone, and it can activate certain channels in the kidney.
Hi everyone. So I just learned about the function of the angiotensin 2, which is derived from the inactive form angiotensin 1 and is helping converting angiotensin 1 to angiotensin 2. And angiotensin 2 is used in a few things. The one of it is vasoconstriction of the efferent arteriole. So when you constrict the efferent arteriole, that means that it will increase the GFR, okay? And then it also helps us with stimulating the posterior pituitary in releasing the antidiuretic hormone, that's the ADH, And it also helps to stimulate the adrenal cortex into releasing aldosterone. It helps the kidney with reabsorption of sodium and H2O, which is water. That I've learned about angiotensin too.
Kidney to help bring back more sodium. The whole goal of this is that you want to increase blood pressure and total peripheral resistance, right? That's the goal of this RAS system. So this active molecule affects several different systems, several different organs to reach this goal, which is to regain the blood pressure and the homeostasis that the body wants. So as we talked about in the image, the angiotensinogen is converted to angiotensin 1 by renin, which is a enzyme by the kidney. However, this is an inactive enzyme. So it can be floating around the body, but it's not actually doing what we need it to do. We need that secondary step to occur, which is where angiotensin 1, the inactive form.
Let me tell you about the RAS regulation. RAS regulation, the full word is renin, angiotensin, aldosterone system. And the RAS system works in the way that angiotensinogen is converted to angiotensin 1 by renin. Bear in mind that angiotensin 1 is the inactive form. We need to turn it to the active form, which is angiotensin 2. And what does this is the ACE. Now, that is very high yield, okay? Angiotensin 1 is converted to angiotensin 2 by the ACE, ACE, which is the full word is angiotensin converting enzyme, okay? Now, let's talk about the function of the angiotensin 2. It helps with vasoconstriction of the efferent arteriole, helps with release of ADH, okay, that's antidiuretic hormone, helps with the release of aldosterone. It also helps the kidney in reabsorption of sodium and water.
Is converted to angiotensin 2, the active form, by this all-important angiotensin converting enzyme, which then can go on to have a whole bunch of effects on the body. So if we think a little bit about why this system exists to maintain homeostasis, to keep blood pressure and peripheral resistance and the volume and the sodium that we need in homeostasis, we can start to think about what kind of things would actually stimulate the release of the renin enzyme. Well, first, a decrease in blood pressure could do it. Right, this is sensed by baroreceptors in the
Hi,
body.
Yusuf. Hello. Thank you for joining me today. How are you doing?
Pressure. If the pressure gets too low, that is a sign that we need to have activation of this system. Why? Because one of the goals is that it's going to regulate blood pressure and fluid balance. It's going to pull more fluid back. It's going to pull more sodium back into the body to help boost that blood pressure and restore homeostasis of what we want. Blood volume, similarly, is going to be sensed by baroreceptors as well. Very similar process. If it senses our blood volume is low, that means we need more. What are we going to do? We're going to try to activate this system so we can get more of that stuff, get more of that fluid and the sodium back into the body. This is commonly triggered by things like blood loss or dehydration, where the volume in the blood decreases beyond what the body is comfortable with. Another way this can be stimulated is through decreased sodium levels. So this is sensed by a structure called the macula densa. And if we turn our attention to our image here, we can orient ourselves where we have Bowman's capsule and the glomerulus. We have the afferent arteriole, right? Blood comes in here. We have the efferent arteriole where blood actually leaves. And then as part of the distal convoluted tubule, we have this sensing area called the macula densa. So what is the macula densa? Well, it's a specialized structure in the kidney that plays a vital role in regulating blood pressure. And it's part of a bigger system called the juxtaglomerular apparatus, which includes the macula densa, the juxtaglomerular cells, in addition to mesangial cells. We'll talk about that in more detail. But the macula densa specifically, or a portion of the juxtaglomerular apparatus, consists of specialized epithelial cells that sense the amount of sodium that reaches the distal convoluted tubule. So if not enough sodium gets there, the body senses that. What is it going to do? It's going to act to bring back sodium. How? It's going to stimulate activation of the renin angiotensin aldosterone system. What if the opposite is true? What if a bunch of sodium is making its way to the DCT? Macula densa says that, whoa, there's a lot of sodium here. This is too much for the homeostasis I would prefer. Well, it's going to act to down-regulate this system, right? So we don't bring back as much sodium, and thus we don't bring back as much fluid. Recall, the principle of osmosis says that with all things being equal, water tends to flow from an area of low solute to high solute. So if we take this image right here, where's the water going to flow? It's going to flow from low solute to high solute. We're going to end up with something that looks more like this. This is a fundamental principle that we use. And so sodium is a solute, right? If the body brings back more sodium because the macula densa senses it's low, more water is going to come back as well. If more water comes back, we bring back more volume, thus increasing the blood pressure. And finally, increased sympathetic activation can lead to increased activity of the beta 1 receptors, which can also lead to renin release. Remember, this sympathetic activation is our fight or flight response. We're mobilizing to either fight or to flee from a threat, increasing the sympathetic system, leading to increased beta 1 receptor stimulation, then leads to activation of the RAS system as a way to help us maintain blood pressure and fluid balance during a time of stress. So just a quick summary to wrap up this video. This is just an overview. We're going to talk about more details here in the upcoming videos, but this whole chapter is dedicated to the renin-angiotensin-aldosterone system. Sometimes this is abbreviated as the RAS system. This is hormonal regulation of blood pressure and fluid balance that is sensitive to pressure, volume, and sodium changes. The pathway here, we're going to take inactive molecules first secreted by the liver as angiotensinogen and ultimately turn it into an active molecule being angiotensin 2 by a very important angiotensin converting enzyme. And it's important to know that there's several ways that we can stimulate more renin from the body. These include things like low blood pressure, low blood volume, low sodium, and increased sympathetic activation. The whole goal of this system is to maintain or restore homeostasis with regards to sodium balance, fluid balance, and pressure balance within the body. Activation.
Now, I would like to tell you when the body releases renin. Remember, renin is released from the juxtaglomerular cells. Is that the word? Let me get the, yeah, juxtaglomerular apparatus, yeah. So now, can we talk about when the body releases renin? Remember, renin comes from the juxtaglomerular apparatus, and the body will release this when it senses one of the following. One is low blood pressure, and low blood pressure will be sensed by the vasoreceptors, the same as when you have low blood volume. This is also sensed by the vasoreceptors. When there is low sodium, this is sensed by the muscular denser. The muscular denser is a part of the juxtaglomerular apparatus, okay, that senses low sodium. And also when there is an increase in sympathetic action, and this one will be sensed by the beta receptors. And in these four situations is when the body releases renin. And remember, what renin does is to convert the inactive angiotensin, no, is to convert the angiotensin, the angiotensinogen. Renin will convert angiotensinogen to angiotensin 1, which is in active form, and then angiotensin 1 is converted to angiotensin 2 by ACE. Okay, and this is when angiotensin 2 can now act when it senses any of the four things I had mentioned earlier. I'm gonna have to do it again, should in case. Does it make sense? Make it make sense. Now, can we discuss why the body will release renin? The body releases renin when it senses one of these four things. Number one is a reduction in the blood pressure, and this is sensed by the vasoreceptors. A reduction in the blood volume, also sensed by the vasoreceptors, and a reduction in your sodium level. The sodium level is sensed by the muscular denser, And also when you have a sympathetic activation, an increase in sympathetic activation, this is sensed by the B2 receptors. No, that's wrong. B1 receptors. Still learning. Let's do these questions together. Okay? The first question I have here is, which of the following simulates renin release? And the answer would be decrease in sodium level. Remember, renin is released when there's a decrease in sodium level, decrease in blood pressure, decrease in blood volume, or an increase in sympathetic activation. Now let's go to the second question. We got that right, by the way. It's asking which enzyme converts angiotensin 1 to angiotensin 2. And the answer is the ACE, which is the angiotensin converting enzyme. And let's see if we got that right. Yes, we did. Next question. A decrease in blood pressure will trigger the release of which of the following enzymes? It will trigger the release of renin. Decrease in blood pressure, decrease in blood volume, decrease in sodium levels. Remember, triggers renin. So we got 3 out of 4. And let's go to the last question. Angiotensin converting enzyme, that's ACE, is primarily located in which organ? Good question. And I think the ACE is located in let me save this. Okay. Liver, located in the liver. Oh, they said it's in the lungs. So ACE is located in the lungs. You're learning. I must have missed that in the video, but glad I missed that. Now I can never get it wrong anymore. ACE is located in the lungs. I know renin is located in the juxtaglomerular apparatus. Okay, so ACE is coming from the lungs. Good to know. Good to know. And the muscular denser senses low sodium level. Basoreceptor senses low blood volume and blood pressure when it's low. And the B1 receptor stimulation senses increase in sympathetic activation. We're getting there.
Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about the effects of angiotensin 2. Remember, from our pathway over here, there's a very important process or a very important system within the body called the renin-angiotensin-aldosterone system. Sometimes this is abbreviated as the RAS system. And within this system, we have a molecule angiotensinogen, which is released from the liver and converted by the enzyme renin to angiotensin 1, which is then converted by another enzyme, angiotensin converting enzyme, to create the molecule angiotensin 2. Our first video was an overview of this process, and now we're going to talk about what are the specific effects that angiotensin 2 can have in the body. There's a lot of different things it can do, a lot of different pathways that it interacts with, and the whole goal is to regain or restore homeostasis within the body. So when we think about the RAS system, remember, its goal is to essentially bring back fluid and sodium, because we know that water follows sodium by the principle of osmosis, and it's in response to states of low blood pressure, low blood volume, electrolyte imbalances, and things the body deems as being out of equilibrium with how it would like to be. So angiotensin 2 is a very powerful hormone within the body and within the RAS system, which is why we're dedicating an entire video to talk about many of the different effects that it can have within the body. These are the most highly tested ones and the ones I'd like you to be familiar with on test day. So first, angiotensin 2 can lead to systemic vasoconstriction.
Of the efferent arteriole
binds the AT1 receptor. Sometimes they'll trick you with a very detailed question. The AT2 molecule binds the AT1 receptor, and this is important because it leads to smooth muscle constriction, which is outlined in our diagram right here. And so why would this be a helpful thing in a low volume, low blood pressure state? Well, because it increases systemic vascular resistance, it increases blood pressure, and if we make a connection to our cardiology content, it actually also increases the afterload in the system, which can make the heart work harder as well. You'll find as you go through a lot of these physiology concepts, there's an integration between the renal system and the cardio system, both in terms of the pharmacology and the effects that one has on another. So be mindful of those compare and contrast, or those concepts you see integrating between the two systems, because oftentimes those are the things they like to test you about. Can you make that connection between the cardiovascular changes? Angiotensin 2 can lead to systemic vasoconstriction. Important to note that angiotensin 2 binds the AT1 receptor. Sometimes they'll trick you with a very detailed question. The AT2 molecule binds the AT1 receptor, and this is important because it leads to smooth muscle constriction, which is outlined in our diagram right here. And so why would this be a helpful thing in a low volume, low blood pressure state? Well, because it increases systemic vascular resistance, it increases blood pressure, and if we make a connection to our cardiology content, it actually also increases the afterload in the system, which can make the heart work harder as well. You'll find as you go through a lot of these physiology concepts, there's an integration between the renal system and the cardio system, both in terms of the pharmacology and the effects that one has on another. So be mindful of those compare and contrast, or those concepts you see integrating between the two systems, because oftentimes those are the things they like to test you about. Can you make that connection between the cardiovascular changes and the renal changes, and vice versa? The next thing I want you to know is that it can lead to efferent arterial vasoconstriction, which can ultimately increase filtration fraction, but preserves the GFR despite the decreased renal blood flow. Now, one thing that's important to know here, this is a preferential efferent arterial vasoconstriction, which means that it constricts it more compared to other vessels within the body. And so to better explain this physiology, let's take an example with our Bowman's capsule, our glomerulus, right? We know things get filtered here into the proximal convoluted tubule. We have the blood entering through the afferent arteriole, and we have the blood leaving through the efferent arteriole. Let's think a little bit about why this physiology plays out here. Just to orient ourselves, we have the glomerulus, Bowman's capsule, right? Things get filtered right here, our GFR, into the PCT, or proximal convoluted tubule. We have the blood and plasma that's entering through the afferent arteriole, and what is leaving through the efferent arteriole, or the EA. So we said this increases filtration fraction, but it preserves the GFR despite the decrease in renal blood flow. Increasing filtration fraction means more plasma is filtered relative to the renal blood flow. And this should make sense to us, right? If we constrict the efferent arteriole, that is to say we make it more narrow, well, now less blood can leave, right? We're going to get a backup of pressure in the system, and increased hydrostatic pressure is going to lead to more being filtered at the glomerulus. And so you're probably thinking, how does this relate to a preserved GFR despite decreased renal blood flow? Well, remember, this system is activated during low blood flow and low blood pressure. So preferential constriction of the efferent arteriole, creating increased hydrostatic pressure, is actually just preserving the GFR. It's preserving the pressure needed to have the normal amount of glomerular filtration rate despite the decrease in renal blood flow. The decrease in renal blood flow is because this typically is a system that's activated with blood loss, fluid loss, or things of that nature. So less renal blood flow, right? Less of it is actually going to the system itself. The body is going to try to maintain homeostasis by decreasing the size or constricting the efferent arteriole, because otherwise, if less blood was going in and it was easy to get out, we would have a decreased GFR. We wouldn't get enough stuff filtered at the glomerulus, and you can imagine this can lead to an imbalance of electrolytes, a buildup of toxins, or other problems within the body. And so really trying to understand that physiology, it's going to preserve GFR, and potentially, depending on the level of constriction, it could increase GFR a little bit. But I think the main point to take away here is that the body has a system in place to keep a balance of what's being filtered at the glomerulus. Now, the next one I'd like you to know is that angiotensin 2 can lead to increased ADH, or antidiuretic hormone release. By triggering an increase in ADH release from the posterior pituitary, important anatomy concept, we're going to increase water reabsorption. This is most readily going to occur in the collecting ducts within the kidney. And so think about what's going to happen to the urine itself if we're bringing back more water. We stimulate the ADH, it's going to lead to more channels being placed in the collecting duct, and more water is going to be pulled out. Well, what's that going to do? It's going to bring back more water into the body, helping restore volume and blood pressure, but it's also going to pull that water out of the collecting duct itself and lead to more concentrated urine in the system. And the effects of ADH are crucial for fluid retention to help restore blood volume and potentially even counteract dehydration. The next one I'd like you to know is that of aldosterone release. And this one's important because it has so many different effects on the body. But again, think about the big picture here. What is the goal of the RAS system? It's to restore homeostasis, it's to bring back sodium, and ultimately replenish blood volume and blood pressure in times of need. So the main thing, the high yield point that I want you to know here is that it increases sodium reabsorption and leads to increased hydrogen and potassium excretion, with the primary thing being this increased sodium reabsorption. Again, I put the high yield by that because the big thing that happens in the RAS system. You activate it, you release all these hormones, you get the angiotensin 2, releases the aldosterone, it brings back sodium, bringing back sodium by way of the principle of osmosis brings back more water. There we go. We've replenished the blood pressure, the blood volume, and potentially even rebalanced the electrolytes by bringing back sodium. sodium and getting rid of some of the other electrolytes. Now, the way it does this is through many different channels and receptors in the kidneys. We talk a lot about that in our dedicated chapter, looking at all the different sections of the nephron, including the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting duct. But an overview is that you get increased activation of the sodium potassium pump or the sodium potassium ATPase. That's going to bring back more sodium and kick out more potassium into the urine. You get increased activation of the hydrogen ATPase as well. Again, this leads to increased hydrogen excretion. You get increased activation of the epithelial sodium channels or the ENaC channels, which again allows more sodium to be reabsorbed within the body. And finally, you get increased potassium channel or ROMK activation, which increases the amount of potassium into the nephrons and ultimately excreted from the body. And so again, big picture here, RAS concept. We want to bring back sodium and we want to bring back water with it. This is helpful for restoring or maintaining our blood volume, our blood pressure, and helping maintain our acid-base balance. The next one that's important to know is that angiotensin II can stimulate the proximal convoluted tubule specifically. This is going to lead to increased activity of the sodium hydrogen exchanger, which is primarily in the proximal convoluted tubule. Bringing back more sodium leads to more water coming back, which again keeps with the principles that we want regarding the activation of the system. You're also going to see direct sodium reabsorption, which leads to more water reabsorption. You're also going to see more hydrogen proton secretion. This is important as it helps regulate our acid-base balance, because when this proton gets secreted, it binds to bicarbonate, which ultimately creates a molecule called carbonic acid. And importantly, carbonic acid can then be further broken down into carbon dioxide and water that are reabsorbed to maintain acid-base balance within the body. So again, all of this system is working to bring back sodium and water and maintain homeostasis with blood pressure and fluid and things like that. But remember, there are other players involved, right? There's other electrolytes that are going in and out of exchangers and channels and things like that. And so the body has to have other systems to make sure we're not creating, a significant acidemia at the expense of bringing back some sodium. It has all of these mechanisms in place, and this is a big player where this happens, that it maintains acid-base balance within the body while still being able to have the effects of angiotensin II and the RAS system to do what its primary goal is regarding fluid and sodium balance. And finally, the last one for this video is that angiotensin II can lead to thirst stimulation. So angiotensin II can act at the hypothalamus to stimulate the thirst centers, and by stimulating thirst, we increase our water intake, right? Our body is going to drink more fluids, and that's going to increase water as well, which can be another way to counteract hypovolemia, low blood pressures, everything else that we've talked about within this video. So just a quick summary to wrap up this video. There's a lot of details here, but let's try to think about the big picture. The goal of the renin-angiotensin-aldosterone system is to essentially get to creating this angiotensin II molecule through the pathway of several different enzymes that allows us to have multiple different effects on the body, with the primary goal to increase blood pressure, increase our total peripheral resistance, and we do this by bringing back sodium, bringing back water when it's needed by the body. And so in summary, angiotensin II is an important, powerful molecule in doing a lot of things like increasing vasoconstriction to maintain our pressures, having preferential efferent arterial vasoconstriction to help maintain our GFR. It can also lead to things like ADH release and aldosterone release, which can act to bring back more water, brings back more sodium, and helping with maintaining a good balance of other electrolytes and ions as well. Similarly, stimulation of the PCT is going to have a lot of different effects on different exchangers and channels within the kidney to, again, maintain that acid-base balance. We don't want to trade one problem for another. The body wants to try to work in synchrony and make sure everything is balanced at the same time. And finally, angiotensin II can stimulate thirst, which makes us drink more water, which is another way to get more water within the body, within the system itself, and help maintain homeostasis.
Now I have to do some questions. I have here, which of the following effect of angiotensin II leads to decreased blood pressure? And the answer is smooth muscle contraction would lead to an increase in the blood pressure. Another question, angiotensin 2 increases the filtration fraction by which of the following mechanism? That would be through contraction too, but let's see. It will contract the efferent arteriole. Vasoconstriction of the efferent arteriole is the mechanism in which it will use to increase the filtration fraction. Because you see, when you contract the efferent arteriole, that's the exit pump, it means that a lot of fluid is going to come in to the glomerulus, and when a lot comes in, it has to filter a lot. So that's increase in filtration, and that would also lead to increase in GFR, but it's not flowing out, so a decrease in renal blood flow. Let's see if we are right. And we are right. I'm super excited. I'm getting it. Which of the following options in the table best describe the effect of aldosterone? Aldosterone. No. So potassium and increase in it's gonna be these two. Okay, potassium. Increase sodium potassium. Is B. Increase sodium, increase potassium. B. Let me show you a close-up of how I was able to solve this particular question here. Okay, and then we can see it right. It's through elimination method. And this is what I did. I know that it works on ENaC, that's aldosterone, yeah. It works on ENaC, and aldosterone help with sodium reabsorption. So I know those two things about aldosterone, sodium reabsorption, and also ENaC, increase ENaC. ENaC is just like epithelial sodium catalyst or something like that. So increase both. So I will just look at the ENaC line, which one increases. So it's B and C. So therefore I can easily cancel out A and D. And I know it also has to increase sodium. So which one increases sodium? B. D decreases sodium. So it can be C, it can be that. So only B. That's good to know. Then which, with regards to antidiuretic, that's ADH. ADH, what it does is to increase water reabsorption. It uses V2 receptors, and yeah, increased water reabsorption means that our urine is going to be very concentrated. Okay, promotes the reabsorption of sodium. It releases is posterior, so not B. Yeah, I think it's C. It promotes reabsorption of water through aqua pouring channels and the collecting ducts. That is correct. Somebody's knowing a book. Angiotensin 2 directly stimulates which of the following renal transporter in the proximal convolutory tubule? So angiotensin 2 simulates renal transporter. In the PCT, we have the sodium and hydrogen exchanger. That's what we have in PCT, sodium and hydrogen. So, and they're talking about angiotensin 2. I think it should be D. Correct. Because, oh God, I wish they would just give us kind of questions in exam. Somebody is hazing it, you know. PCT, sodium and hydrogen. Angiotensin 2 acts on what brain structure to increase water intake? Hypothalamus. It will act on your hypothalamus to stimulate test. Fun fact. Fun fact, guys. Do you know that angiotensin 2 acts on your hypothalamus to increase test? Like, seriously. Because angiotensin 2 helps with fun fact, guys. Do you know that angiotensin 2 will act on your thalamus to increase test? And this is because angiotensin 2 helps with water reabsorption. So it's going to trick your thalamus into feeling thirsty so that you drink water. So angiotensin 2 helps with water reabsorption by stimulating the hypothalamus. Fun fact, guys. Fun fact, guys. Fun fact, guys. Do you know that angiotensin 2 helps in test simulation? And it does this by acting on the thalamus. Fun fact, guys. Do you know that angiotensin 2 helps with test simulation? Because it helps in water reabsorption, it's going to act on your thalamus to simulate test. Hence, you drink more water.
Hey, welcome back everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about an important concept, which is that of natriuretic peptides. This is a really important concept to understand because it builds on some of the stuff we've previously talked about in this chapter as it relates to the renin-angiotensin-aldosterone system. Remember, big picture overview, the RAS system, or the renin-angiotensin-aldosterone system, is working to keep the body in homeostasis. It's working to keep the balance between fluid, volume, pressures, and electrolytes so that the body is able to function optimally. Additionally, it's responding to different changes, right? If we need more sodium to bring back more water, this system allows us to do this. But what happens if we've gone too far the other direction? What if we have too much water? What if we're retaining too much fluid? What's the body's response to managing this? Introduce the natriuretic peptides. So first, let's talk about a general overview, which is that these peptides, which are hormones, act to regulate blood pressure and fluid balance. They are secreted in response to volume and pressure changes, but in the opposite direction as the angiotensin 2 molecule. Just as a quick refresher, the angiotensin 2 molecule is the product that has a lot of effects in the body from the RAS system. We go from inactive forms to creating this molecule, which then can have a lot of different effects in the body, including vascular smooth muscle constriction, release of ADH, aldosterone, and effects on different channels in the kidneys, which we highlighted more specifically in our dedicated video on the effects of angiotensin 2. But in this video, we're going to highlight a couple of different key molecules. The first is ANP, or atrial natriuretic peptide. This is released from the atrial myocytes due to atrial stress, so the atrium being in the heart, right? ANP, atrial natriuretic peptide, and ultimately what this is going to do is it's going to act to inhibit the RAS system, right? So it's the opposite of the RAS system. We've gone too far. Our homeostasis is disrupted, but in the other direction. And why does this happen? Well, what kind of things would trigger this? Well, if we have too high of blood pressure or we have too much blood volume, the body senses this overflow. You get a stretch of the atria in the heart, and the body's going to act to do the opposite of what the RAS system is intended to do. Recall, the RAS system is usually going to work to bring back things like sodium, which ultimately brings back water. So if this system is doing the opposite, we can kind of think about what those effects might be. When this system is activated, when these hormones are released, we're going to get increased sodium excretion. That is called natriuresis. That's where these peptides get their name from. We are also going to see increased water excretion or diuresis, right? Patients are going to be peeing more. Why does this occur? Well, it gets back to the principle of osmosis. If we use this as an example and we say, which way is water going to flow? Is it going to flow from low to high solutes or high to low? Well, the principle of osmosis tells us that water is going to flow from low solute concentration to a high solute concentration. So in the RAS system, we are bringing back sodium, which then brings back water because of this principle. And here, we're seeing the opposite occur. We're increasing sodium excretion, which means more sodium is staying in the kidneys, and thus that's bringing more water into the kidneys and the tubules as well to ultimately be excreted from the body. We also tend to see afferent arterial dilation and efferent arterial constriction, which overall has the effect of increasing GFR. And why does this occur? Well, to orient ourselves, right, we have Bowman's capsule and the glomerulus, and then we have the PCT, the proximal convoluted tubule. We have the AA, the afferent arteriole, coming in, and we have the efferent arteriole leaving this structure. So now let's do a thought experiment. What happens if we get dilation of the afferent arteriole and constriction of the efferent arteriole? That is to say, the afferent arteriole becomes wider and the efferent arteriole becomes more narrow. Well, what's going to happen to the GFR? We're going to have more fluid, more blood, serum coming into the system, and less ability for it to leave. What happens there? We're going to get a backup, right? We're going to get a backflow, and that's going to give it an option to be pushed out. It's going to increase our hydrostatic force into the PCT. It's going to increase our GFR, or the amount that is filtered at this area, because more volume is coming in. There's less ability for that volume to leave, and thus it has nowhere else to go but to be filtered as part of the GFR. We are additionally going to see things like decreased renin and thus decreased aldosterone, because if we look at this system and we look at this pathway, renin is a key component to making this happen, right? Allowing angiotensin II to be active, take effect, and lead to more aldosterone. So if we decrease this enzyme activity, we decrease this pathway, we thus decrease the amount of aldosterone that is released. Now, we also see things like vascular vasodilation, because ANP causes the blood vessels to relax, thus reducing vascular resistance and lowering the blood pressure. Now, another one they like you to know about is BNP, or brain natriuretic peptide. This is one that comes from the ventricles. It's released from ventricular myocytes due to ventricular stretch. You're probably wondering, why isn't it called VNP if it's from the ventricles when ANP is from the atria? This has to do with kind of its origination and where it was first discovered, because it was actually originally discovered in brain tissue, thus BNP just kind of stuck with it over time. And the principles that you need to know for this are the ones that we just talked about. It's really the same stuff. It inhibits the renin-angiotensin-aldosterone system, or the RAS system, by way of the same mechanisms that ANP does it. As you can imagine, these have similar effects, and they're typically going to be released in synchrony with one another. If you get stretch in the atria, oftentimes you also get stretch in the ventricles because there's fluid overload. There's too much stuff in the system. The body needs to act to help get rid of some of it. And finally, the last thing I'm going to point out in this video is just a general overview of the molecular mechanism. We're not going to go into all the detailed biochemistry here, but I do think it's important for us to think about connections between different systems that we learn about in preparation for our exam, because that's how they're going to want to test us. Are you able to connect one concept to a different system or a different organ? And so the earlier we can start to think about those things, the more successful you're going to be on test day. So the general principle here is that ANP or BNP will bind to a natriuretic peptide receptor, which then activates guanylyl cyclase. This then converts a molecule called GTP into cyclic GMP or cGMP, which can then go on to activate another molecule called protein kinase G or PKG, which ultimately has the effect of leading to vasodilation. So we draw these key points here. We have stimulation of GC or guanylyl cyclase. GTP is converted to cyclic GMP, which then activates protein kinase G and ultimately leads to increased smooth muscle relaxation. So just a quick summary to wrap up this video. The overview of this principle is that these natriuretic peptides do the opposite of the RAS system and the opposite of angiotensin II. ANP is released from the atria and promotes water and sodium excretion. It increases GFR, inhibits the RAS system, and reduces blood pressure overall. BMP has very similar effects, but it is released from the ventricles. It also has clinical significance in the fact that we use this one when we are concerned for a patient having heart failure. We order this lab and check and see how high it is, as it can be an indicator that there's a fluid overload within the body, within the system, or specifically the heart. And finally, just a general overview to tie in some biochemistry. Both of these molecules work through the cyclic GMP pathway, which lead to smooth muscle relaxation and ultimately fluid elimination from the body.
Remember, the body releases renin when it senses a decrease in blood pressure, a decrease in blood volume, a decrease in sodium levels, and renin moves into action to increase all this decrease. Now, do you wonder what happens when we don't have a lot? Remember that the body releases renin when it senses a decrease in the blood pressure, a decrease in the blood volume, and even a decrease in sodium levels. And renin goes into action to increase all this decreased volumes, pressure, or levels, right? But what happens when renin has done too much? The body has something else that counters this, and it is called the natriuretic peptide, NP. I know it to pronounce it as MP. So the MP then, what it does is that it inhibits RAS. RAS, remember, is the renin, angiotensin, aldosterone system. So it stops renin, okay? And what this does is that it's going to help us to now excrete the excess. So there will not be excretion of sodium, excess sodium, excretion of excess water, so that the volume of the blood is normalized, okay? And also it will lead to a decrease in renin, which will in turn reduce aldosterone. I hope this makes sense. No. No.
Go ahead and take a couple moments.
Okay, at this point, I think I'm just gonna pause to end the video and I'll come back later. It's time for lunch. Thank you so much for joining me today. I hope to see you again tomorrow or later today. Still studying.